Alrighty. Good afternoon, everyone. Thanks to all that are joining online and in person. I would like to welcome you to Project Echo, a program that Dr. Santos and Dr. George founded. This initiative hosts monthly sessions with specialists from our Health Sciences Center to educate primary care providers in the rural and underserved areas of West Texas. The goal is to address key metabolic and health disparities through case-based scenarios with hopes of reducing unnecessary referrals, labs, procedures, and ultimately drive down healthcare costs for our patients. You may occasionally receive emails from our Project Echo team inviting you to host a presentation or participate as a panel specialist in the future. Keep an eye out for these exciting opportunities. My name is Milka Puvakari. I'm an MS2, and I am the president of the Project Echo chapter at RT2HSC School of Medicine. Before we begin, a few quick reminders. If you're attending online, please stay muted throughout the presentation. CME credits are available for this event, but you must complete the evaluation survey at the end of the presentation. We will have a reminder at 12:55. For those attending in person, please ensure you've signed in on the paper in the front and in the back. This educational activity is supported by the Texla Telehealth Resource Center, a federally funded program of the F. Murray Hall Rural and Community Health. Now I'd like to hand it over to our MS2 that will be presenting, Patrick Udeni, to present today's case alongside Dr. James Tarbox. Thank you.
Hello, everybody. Today I'll be presenting the case for Dr. Tarbox. So a 19-year-old female was referred by her PCP due to hives that started about 2 months ago. And at that initial visit, a specific IgE testing to different environmental and food allergens were obtained at the time. She noted that her hives can occur anywhere around her body, but it was most common in her joints, like her knees, elbows, and hips. And she would take diphenhydramine as needed to alleviate her symptoms. She also reported that eating a banana recently caused some itchiness in her throat and made her feel like her body was on fire. She also noted that she had a trip recently to San Antonio for a few weeks ago for the weekend, and she didn't experience any hives during the trip or 2 weeks after. She states that her symptoms are intermittent, and she denies shortness of breath, chest pain, fever, cough, and nasal congestion. She noted that she's eaten sushi and developed an itchy sensation in her throat as well, but she wasn't sure if it was because of the rice or the fish. And in the IgE test that the referring PCP got, there were many foods that were listed as allergenic that she noted eating in the past and not causing any reactions. And the IgE test was positive for cedar, cat, and several molds, and it was kind of insignificant or inconclusive for banana, corn, mustard, oat, rice, tomato, and wheat. She has a past medical history of general anxiety disorder, ADHD, and intermittent asthma. She has no past surgical history, and the medication she currently is taking is norhistamine, ethinyl estradiol, albuterol, atomoxetine, ibuprofen, sertraline, trazodone, and diphenhydramine. She lives currently in an urban private home with 3 other people for 2 years, and her review of systems was all negative other than what was stated in the HPI. At the initial visit, her temperature was 98 degrees Fahrenheit. Her heart rate was 126 degrees. Her respiratory rate was 16. Her blood pressure was 102/69. Her oxygen saturation was 96%. She was 163 centimeters, 70.31 kilograms, putting her at a BMI of about 26.46. The rest of the physical exam was benign, other than normal sinus tachycardia, and she also had no urticaria. So these are the labs that were the IgE labs that were gotten at the last at the referring PCP's office, and as we can see, it was significant for mountain cedar allergy and cat epithelium and dander as well. It was also significant for Alternaria, Cladosporium, and Aspergillus. The test also got a lot of different it tested for a lot of different food allergies, 21 or 28 to be exact. And most of them were pretty inconclusive or insignificant. In the clinic, Dr. Tarbox got epicutaneous testing, which was positive for different trees, molds, and cat hair, as well as tomato, but was negative for milk and wheat. She also had mild dermatographism. So Dr. Tarbox diagnosed her with intermittent urticaria, oral allergy syndrome, and mild dermatographism. And this was because of the physical exam that the information was given in the last slide. So the plan was to diagnose her or to prescribe her citrizine 10 milligrams daily to stop diphenhydramine. And if her hives are not controlled after this plan, a further workup would be considered. Dr. Tarbox also advised her to cut out tomato from her diet and to avoid banana because of her history and her physical exam. And now Dr. Tarbox, the division chair of the Allergy and Immunology Department at TTUHSC, will continue this talk.
All right. Thank you very much, Patrick. And I think the reason I decided to talk about this subject was because I'd had several referrals in a row, especially in April and May, where I kept noticing that I was getting referrals for food allergy, and yet there'd already been pretty extensive workup done with food panels. If nothing to disclose, here's our outline, mainly common food allergies. How do you go about testing them? A differential, as well as what are some of the latest treatments and management. So if you look at it as far as prevalence of food allergy in children, there's a lot of surveys. It usually ranges anywhere from 7 to 10%. And some of these reactions overall, about a third can be severe, and multiple of them will have food allergies. And so your most common food allergens are usually milk, egg, and peanut, but shellfish has also been on the rise in kids. In adults, we tend to see more shellfish and fruits. And once again, it just depends on, you have new surveys or databases coming out all the time, but a recent one in 2019 showed 10% of adults and related it to shellfish and tree nuts as opposed to the earlier one, which was 2014. And I think anyone who obviously has been at my clinic and anyone who's being seen for food allergy, a good thing is always to think about, well, what are your 9 most common food allergens? And so those include milk, wheat, and soy, shellfish, fish, tree nut, peanut, and egg. And then in a few slides, I'm going to talk about sesame. And so these 4 right here, milk, egg, wheat, and soy, they tend to represent, all food allergens can be serious, but some of the ones that are a little more benign and you tend to outgrow them. And so that's here, 50 to 90%, you'll outgrow these. And these 4 here, peanut, tree nut, fish, and shellfish, tends to be less, closer to 10 to 30%. And they're also the ones that tend to have more severe reactions. And used to be the big 8, now it's big 9, and that's because in 2021, they decided to add sesame. And so then in 2023, the law got approved and they had to be included on labels. And part of that is because the reactions with sesame, well, first of all, it's becoming more common. Second of all, about a third of reactions can be severe. And lastly, there's pretty good cross-reactivity, about 6-fold between sesame and peanut. So I just bring this up because I saw it so many times when I was in fellowship. I don't know, maybe it's because in St. Louis, they really like goat's milk, but you have a 2-year-old show up to your clinic, history of milk allergy. Mom's wondering, well, what can she drink? and it always came down to like goat's milk for some reason. And now if you're in the store, you'll notice that this Brahms A2 milk is on the very top shelf and very prominent, and people are trying to sell it. Can you eat a burger? Can you drink mare's milk? And so the answer is actually mare's milk has the lowest cross-reactivity. And so that's shown here in this figure right here, where you have cow's milk. Obviously, cow and beef allergen, it's not really cross-react. It's more of just, they just tend to go together. But cow and goat definitely overlaps at 92%, 4% for mare's milk. And soy is pretty low too. So usually you can tolerate soy milk. If you look here at peanut versus legumes, it's pretty low. But peanut and tree nut, yeah, about a third. And then soy is can be pretty high too regarding legumes. And then lastly, I mentioned oral allergy syndrome in my diagnosis, but I get consults for this all the time where people eat, peaches or melons or apples and their throat just really itches. And so that's less of a true food allergy and more of pollens like birch and ragweed and grass look like foods to your body. So yeah, this is good to see an allergist because then you can get skin tested and figure it out. Tends to be milder overall though. So I know this is common in every field of medicine, but by far you have to take a good history. And I know sometimes it's not easy, and that's also why when we see patients in my clinic for food allergy, we'll easily spend 10, 15 minutes just going over a history, just trying to make sure you get everything that's going on. You got to come up with a good differential. We'll do skin testing or serology, a lot of the times both. And then, we can see what happens if they eliminate fruit from their diet. We can see what happens if we challenge them. And so just all of this kind of goes into what it takes to evaluate food allergy. I'll commonly talk to, people rotating with me and say, evaluation of food allergy is more like just being a detective. So, how do you go about, once again, with food allergy? And do you have IgE, non-IgE? Is this just an intolerance? And then we'll decide to, do skin test, do you do serology, do you do serology with component testing? And component testing basically is where if we're like evaluating for peanut allergy, you can break down ERA H1, 2, 4, 8, and 9, rather than just the simple overall peanut allergy. So that can be helpful. But always consider your pretest probability. And this even goes back to if you're just going to see someone in your clinic and you're like, hey, they said this is, every time I, eat a peanut, I break out in a reaction. Well, that's a high probability. But if it's, I ate peanut butter today and did fine, but then a few months ago, I had some Ritz crackers with peanut butter and I think my mouth itched. Well, okay, I don't know. Maybe you test, maybe not. But what you don't want to do is have someone kind of like what happened in the introductory case where they're like, oh, maybe I react to peanut, maybe I don't, maybe it's fish, maybe it's rice. And then you order a panel with 28 items and then it comes back with 10 positive results and you're staring at it like, what do I do? Well, you know what you do, you refer to me. And then, then I have to kind of sort through all that. But then that just leads to a lot of confusion. That can lead to restriction in people's diets, which is a big deal. I always tell the story of I had a guy who grew up in Louisiana, but he kind of moved around the country. I think he was in some federal government position, but then he ended up retiring in Lubbock. And he came to me because he was told that he shouldn't eat chicken, black pepper, and rice, but he loved Cajun food. And so I skin tested him. And then I did some serology and I'm like, you realize you're not allergic to anything. He's like, what do you mean? I've been told for 10 years to avoid all these foods. And I was like, well, what happened? And he said, well, someone skin tested me and said I should avoid all this. So that evening he went home and he had some etouffee and some other stuff. And he was the happiest he had been in years. So like stuff like that can happen. And yeah, negative tests, negative history. You got to take all this into consideration before you decide to tell the patient to do a challenge, or in my case, sometimes do challenges in clinic. And just like everything in medicine, you got to reevaluate. So this kind of breaks down skin testing versus specific IgE. And skin testing tends to be more sensitive, while IgE can be more specific, but that's changing all the time now. I would guess sometime in the next 10 or 20 years, IgE will be both sensitive and specific. Skin testing is quicker. You get results in 15 minutes rather than a few days. Obviously, they're on antihistamines and you have to go straight to serology. And I mean, even now, I mean, this paper is 2015, but it's still kind of the leading paper that showed what happens if food panels are done before a patient gets sent to an allergist. And the big thing to see here is, you know, they reviewed all these charts, almost 300 people had food panels ordered, and really only 90 of them were even warranted to be worked up for food allergy. That doesn't even include doing a whole panel, but just to even do some testing. And what this kind of shows that if you take 284 people and you do a food panel, really only, and you come down here and they don't have a good history, only 4 out of 184 was actually a true food allergy. That's kind of a summary of all of this here. And yeah, a lot of these people were told to avoid foods. They started reintroducing food and did fine. So yeah, you have a 2% positive predictive value if you order a food panel without a good history. Those are not good odds. So this kind of goes over allergens versus intolerance. This was based off a 2019 paper where they surveyed a bunch of people who thought they had food allergy, but half of them were wrong. They actually just had food intolerance. And I mean, that's kind of the big point here. It's food intolerances are annoying, but they're not life-threatening. You get more kind of GI issues. And I don't agree with everything on this figure. Like down here, it says a molecule of food. I mean, that's not quite true. There's usually a threshold, but it's usually much lower than it is for food intolerance. And over here with diagnoses, I know people in GI will be like, hey, don't forget lactose intolerance. We actually have tests. But yeah, you don't usually have tests for most of your food intolerances. And also, as far as management, usually with food allergen, once you know your threshold, that's it. You can't vary it, as opposed to intolerances where sometimes you can tolerate more at other times, and you don't need epinephrine for intolerances. So obviously, a lot of people get referred to me because they want to know this patient has an issue with food, how much of it's IgE. We'll look at it. IgE is way over here, maybe a little bit here. But then you have all these other reasons. I mean, you have non-IgE, cell-mediated, which we'll talk about in a little bit. All these metabolic reasons. Sometimes it just happens because that happens with the food, like with caffeine, tyramine, serotonin-like reactions. Scombroid, I had a patient who saw me in March for potential scombroid because she ate it's less common with freshwater, but it was tilapia from China. And then she did her own searching, and apparently this company got called out and had been reported to the CDC. It's pretty interesting. And yeah, you have all sorts of reactions like MSG and sulfites, which are non-specific reactions. So yeah, I have this big table here, but I'll break it down into something easier to read. Where once again, IgE, food allergy, your prevalence is anywhere from 0.4 is a little low, but probably 4 to 10%. Higher in kids than adults, but adults have been climbing in the last decade. We already talked about the 9 most common allergens, how it presents, how you work it up. I mean, oral immunotherapy we'll talk about later, sublingual, all this. As far as mixed or cell-mediated, this food allergy with atopic dermatitis is interesting. Your most common ones are usually milk, wheat, and soy, where it's sometimes we'll evaluate people because they'll come in, they'll be wondering why they have eczema and it won't go away. And it's actually, there's some relationship to food. EOE, obviously this is GI's favorite thing. It's one of the more common reasons people get seen now. I know this is 1 in 2,000, but some surveys, and I'm sure America's probably closer to 1 in 1,000. And the thing here, though, is patients get sent to me a lot for food allergy component. We used to think it was much higher. We used to say it was 70, 80%, but the more and more we've tracked it, it keeps dropping down to 30 or 40. And so it's not usually food allergy concerning, but we still see them. And good news with this is we have much better treatment for EOE now than swallowing inhaled steroids and going on really draconian food elimination diets. And then here's the other kind of eosinophilic GI disorders with the colon and, duodenum and stuff, because you have Dupixent here. And so I was sitting here because I know people sometimes ask her like, why is eosinophilic esophagitis more common? And I mean, I'll just go over a few of the things, but some of the stuff has to do with, the increase in C-sections. They've got some pretty good studies regarding antibiotic exposure in infancy, proton pump exposure in infancy. And then I was wondering to myself, I was going over trying to make sure I was up to date with the latest on this topic. And then I was thinking, I wonder if Sarah's going to be here today. GI ever show up to these things? She was part of a systematic review. I thought that was kind of cool. All right, so there's a lot of factors in food allergy. And this kind of goes back to the earlier slide where sometimes you need other stuff to trigger a food allergy reaction. So taking alcohol, taking NSAIDs, working out, you have exercise-induced food anaphylaxis. Sometimes when you heat up the food, that'll actually reduce your chance of reacting by about 80%. And this also goes along with amount. Sometimes, people react to, 20 milligrams of a peanut. Sometimes it's 100, 200. All right, as far as other management is concerned, obviously avoidance, we've been doing forever. But one of the things to remember is that even if you try to avoid the best you can, you still have reactions every year, whether it be through accidental exposure or purposeful, 10% here. And 10% of these reactions can be severe. This happens no matter what. People just don't want to use epinephrine, but hopefully that'll be changing soon, as I'll talk about later. Here's your management. You have to include, what food allergens are contained. I always tell my patients, if you're going to go eat out at a restaurant, hand them a card. There's just a lot that goes into the management. It's especially if it's an infant or a young kid, it's real tough on the parents. And the other thing is this cross-contamination issue, that's only voluntary. Just want to bring that up. So if you have a kid with food allergens, you got to make sure there's no potential cross-contamination. So epinephrine, EpiPen's been around since the early 80s, at least marketed like this. And then AviQ came out later in the 2000s. This is the one that talks to you. I always thought it was kind of neat. But then they ran into and it's smaller, but then they ran into an issue where their dosing was 10% off or even up to 20, only in a few pens. That was enough for the FDA to pull it and tell them to redo the whole mechanism. So it took them several years to get back to market. There's your general epinephrine pen. Obviously, this looks fancier than this. But what's interesting in the last few years, there's been a lot of research looking at, can we administer epinephrine in other ways? So this is Neffy. It got approved last fall. It's nasal. And we're still waiting on actual data in people with allergies and anaphylaxis, but the pharmacokinetic data looks good. You have one small report from Japan in children. I think it was 15 patients. But yeah, in the next year, you're going to have a lot on this. And hopefully this will get over the needle aversion so that 30% rate of epinephrine use will hopefully at least be above 50. You have another one that's expected to be approved next year called Anafilm. I think the concept's sort of interesting, but I'm a little worried about the fact that if someone's having a severe anaphylactic reaction, can you get them to open their mouth? I don't know. We'll see. We'll see how it goes. It's an interesting concept, though. I always, all the residents and some of the medical students know this. I always want to know, well, what is anaphylaxis? I want the definition. Most of them, before they've heard me talk, always just want to give the underlying, pharmacology and what happens. But basically, it's two organ systems, or it's your skin plus another organ system, and you have reactions in both, or it's hypotension in the setting of a known allergen. So that's kind of what that is. So, whether it's skin/mucosa, respiratory tract, GI, from a cardiac standpoint, you get hypotension. It's much more rare, but you can do from a neuro standpoint, you can have seizures. And so that's your two organ systems or more after a possible allergen versus hypotension. All right. So here we have, early treatment of people with food-induced anaphylaxis with epinephrine. Well, once again, here we have, at least in this case, it was 60%, but only 2/3 of them took it early. A third of them got it in the emergency department. So the reason that's important is because look at the discrepancy in being hospitalized. You have almost like a 26% increased chance of being hospitalized if you wait to take your epinephrine. So, and a lot of it is needle phobia. Like a third of patients will not take the epinephrine because they're worried about the needle. So hoping if the nasal spray becomes more popular, and also if insurance companies stop denying it, which is getting really annoying, that this will increase a lot. So oral immunotherapy, sublingual, this has been going on now for decades, but it's required a ton of research, trying to figure this out. It's not easy. It takes a lot of work. You got to go back to your allergist every week or two to updose. Nearly everyone will react. Most will need epinephrine. You get this risk of EOE, and you end up, and I always have to tell people this, you're sitting there eating the equivalent of several peanuts or an egg or a glass of milk every day, but you got to keep doing it every day because your chance of sustained response can be pretty low, especially if it's peanut. A little better with egg and milk. Then we talk about Palforzio. This was supposed to be the next big thing in food allergy, that everything lined up in 2019. And then, of course, the pandemic happened, and also it's just not the easiest thing to do. So Nestle lost billions. I think it was $3 billion in Palforzio. That's got to hurt. They ended up selling it to another Swiss group called Allergies. They're still trying to get this to work. I don't think it's ever going to come back to even being used much. This peanut patch, DMV has been working on this. I know this is 2014. DMV's original animal studies go all the way back to, I think, 2008. So I know people like to joke that, oh, pharmaceutical companies have all this sway and everything's going to go smoothly. Well, that sure as heck didn't happen with DMV. They're still not approved. It's a great idea. Just throw a patch on your skin once a day. The reason why they got nullified a few years ago was the patch was so weak, it kept falling off. So then they increased the adhesive on it, and then people started reacting to the adhesive. They couldn't get it. It was just kind of a sad situation. I'm like, or DBV, sorry, I was saying DMV. Poor DBV. They've been trying a long time. And I think they're going to get there, but it's right now, the next time that they'll go before the FDA is 2026. And they almost went bankrupt last year. All right, outmatch study. So, there's like a few studies when you think about food allergy that just are, like, I would consider some of the most important in the last decade. LEAP from 2015 and outmatch from 2024. Yeah, I think it took 7 different large food allergy centers in the country. And I'm just going to skim it because I've talked about it before. And also the end result is basically if you take omalizumab and you you're allergic to not only peanut, but two other food allergens, it just does a really good job of nullifying a food reaction. And so that's what they looked at. And they looked at peanut, cashew, egg and milk, walnut, hazelnut, and wheat. And pretty much all of them did really well except for cashew, which is the joke they always say is cashew is just a tough nut. Okay, whatever. But yeah, but the interesting thing about cashew is once you've been on omalizumab for at least 6 months, it starts trending up closer to 60%. And this here shows that if you did your food challenge to 2 foods or even 3 foods, you could reach the threshold of what they consider being able to tolerate an accidental exposure at a fairly decent dose of 50% if you did 2 foods. 3 foods probably could have been a little better, but still 25 to 50. So yeah, that's the benefit. And I mean, one question would be, do you put everyone on this drug? Well, you look at it about, anywhere from 8 to 10% of your population has food allergies. So I know we kind of joke like, how big do your studies need to be? The study was 180 patients and 3 adults. But the other thing you got to remember is, the way the study was set up and the fact that, this wasn't the first study to look at Xolair. There's been several others, just not as this well done. And also our safety data for Xolair goes back over 25 years. And, but that's the thing. And that's what I always have to tell everyone. You have this 1 in 750 chance of reacting to Xolair itself. That's another reason why I can't just be like, hey, everyone start this if you have food allergy. And I just put this in here that if 5% of all patients with food allergy were started on Xolair in the next few years, you'd have 2,000 severe reactions. That's not good. And there's like concerns about, what about other foods? Yeah, shellfish. There's a group down in Houston working on shellfish. Wheat was already covered, but they're just going to do so many other foods with omalizumab. And you always have to factor in the cost. Xolair is not cheap, $30,000 to $60,000 annually. So something's got to give. But then again, I guess you could always argue, and that kind of goes back to, if your kid ended up in the hospital from a food allergy reaction, well, that's not cheap either. So that gets around to, yeah, I don't think it's for everyone. But I would say anyone who's had multiple reactions and hospitalizations, then the offset is probably at least somewhat close. Someone who not only has food allergy, but maybe also has asthma, atopic dermatitis isn't as good, but maybe chronic urticaria, then that's like you're getting 2 birds with 1 stone. And several of my patients are actually, they're like high schoolers about to go off to college and their parents are worried. I keep telling them, it's like, I really hope your kid, when they go off to college, is going to stay on the Xolair. I'm sure they'll start it. I don't know if they're going to take it every month. So yeah, this just kind of goes over how Outmatch was set up. This was stage 1. So where they were on it for, 16 to 20 weeks before they got challenged. Stage 2, they still haven't reported it yet, but I'm assuming it'll be out this fall, where they actually compared Xolair to oral immunotherapy. It was actually pretty interesting. They presented the results in March, or I guess late February, at the allergy meeting, and Xolair actually did better. So it was 31% about 19. Of course, the numbers were small, but it was still interesting. And then stage 3 is going to be interesting, where they follow people on a diet, do rescue Xolair. That'll take a while versus food avoidance. All right, I had to at least throw up one slide with a bunch of cells, but I'll, oh wait, yeah. And so the first one I was going to show was, here's omalizumab over here. I don't know why they had it going at a TH0, but whatever. It should actually be going more at the dendritic cell. But then also you have Xolair over here with its reaction on mast cells, basophils, IgE. And then you have these other anti-IgE like molecules. Talzumab was actually one of the first, but it must not have worked well because It hasn't been studied since 2003. Ligelizumab has been studied a lot in the last 5 years, but Regeneron, who owns ligelizumab, also owns omalizumab. So obviously, there's a little conflict of interest there. And so you have all these other molecules. There's dupilumab, which I know I've talked about a lot in my lectures, works on anti-IL-4 and 13. They're trying to get into the food allergy space. But for the first time in a long time, one of their phase 3 studies just completely failed in Europe. So I don't know what happened. I got to read it. It just came out last month. Tezepelumab, they're trying to get approved. It's anti-TSLP. People like this because it's so much higher up in the cascade. But there's also this question of if you block this high in the cascade, you have feedback loops. There's tocilizumab, which is once again IL-33, very high up in your cascade. But it actually has some pretty good data so far. It might be next. Abrocitinib, I mean, we're using JAK inhibitors and everything now. I don't use them as much, but Rheum and Derm love them. And so they get used a lot. They're being studied. Abrocitinib may not be the first JAK inhibitor to get approved. That'll probably be remibrutinib. And then lastly, I just thought this was an interesting topic. So we're going to talk about nanoparticles. So Michigan has been looking at this now for probably at least a decade. And so they were looking at this nanoparticle called polylactide co-glycolide. It's abbreviated to PLGA. And it's been around for a while. It gets used a lot in as a way, I guess, to make it so that if you infuse medicine, it goes away, it goes okay. And so here they were trying to see if they infused, in this case, it was ovalbumin because it was a mouse model with egg. If you wrap the ovalbumin in this PLGA, could the mice then not get anaphylaxis? And then another thing that they've been looking at is what about celiac disease? So they actually did this study back in 2021 for those who are interested in GI. And they took gliadin and wrapped it in this molecule, trying to see if they could reduce inflammation in your intestinal tract. Short story, yes. Long story, they weren't looking at symptoms. Phase 3 study, 2026. So yeah, they took mice, infused them with the ovalbumin, with the encapsulation, and they did significantly better. None of the mice died when they were exposed to the egg. Some did without. And they were able to take biopsies from the intestinal tract, as well as looking at dendritic cells in the spleen, and show you got this overall shift from Th2 cells to your T regulatory cells. That's what the FOXP3 is. I had to look up because I'd forgotten what CD73FR4 is, but basically that's just an anergic state where the cells just stop responding to anything. Lastly, what can you do with food allergy in the setting of telemedicine? I would probably think that follow-ups are easier than the initial visit just because you have to cover so much, maybe do skin testing, but for follow-ups, you could probably easily do it with blood work and then just talking, following up with how their diet is and everything. You can give more education, can talk about auto injectors. Like I can't tell you how many people in the last 6 months I've talked to about Neffy. They're like, oh, that sounds great. And then I try to get it approved and their insurance fights it. It's just its own thing. And then, obviously this time of year, I get so many letters of, hey, can you fill out these 2-page form because my kid needs to make sure they're sitting at a food allergy free table in school and that the nurse has the epinephrine pen or not. And, Texas passed a law this last year where pretty much every medicine they could potentially be on has to be covered. Yeah, that's another example of why you shouldn't let politicians decide how to do things. That was ridiculous. And then here you have improved access for rural or underserved patients because, yeah, I mean, I guess it was yesterday. Yeah, yesterday I had 2 patients. Both patients drove 2.5 hours to see me. So yeah, that's why, in some cases, telemedicine could be useful. Post-emergency workup, and then, yeah, if they just want to talk quickly after an talk soon after, that's good. But yeah, I think the main takeaways from this talk would be, just if you're going to see, if for anyone who has a food allergy, you could always just go over the main food allergens first before you start delving into some of the more rare ones. History, just like in everything, is important. I would just try to, like, if I could, I would delete that food allergy panel that's in Cerner, but I can't. I think it's just not a good thing to be there. Kind of like cow's milk IgG. I don't know who put that in there either. And just try to be a little more focused. I mean, I'm not saying that like maybe once or twice a year I'll test someone by a panel to 10 or more foods, but it is by far not the norm. I probably on average only get blood work for foods. This is for people coming to me for food allergy. I'll maybe test 1 to 3 foods. Be able to differentiate between food allergy, IgE, non-IgE, food intolerance is helpful. And then lastly, we're getting a lot, at least now we have omalizumab, especially for patients who've had severe reactions or multiple foods. That gives not only the patient, but also the parents some peace of mind. You got several other biologics they're looking at. We'll see if this nanoparticle thing works out. And yeah, and also we have better access to epinephrine for those who are needle phobic. Okay, finished almost on time. All right, what questions, or you want to say something, Dr. George?
So I'm curious to know if what kind of rice allergy is rice allergic to people, or because I'm a rice eater.
Yes. Yeah. So do I need to talk more?
Okay, I'm sorry. Go ahead.
Okay. So question is rice allergy, and I think how long would this be now? I would say that in at least the 15 years I've been doing this, I think I've seen 2 patients allergic to rice ever, and semi-joking, semi-serious. I tell people that if you're allergic to rice, especially if it was more than 50 years ago, you probably didn't live long. So yes, rice allergy is exceedingly rare.
And is it brown or white?
The 2 I saw were white.
Does anybody else have questions that they would like to ask Dr. Tarbox? Thank you, Dr. Tarbox, for this very informative session, and I'm hoping that we will have many more sessions related to allergies. Yeah.
Hello, everyone. Thank you for attending today's Project Echo Grand Round session. Just a reminder, please sign in on the paper in the front or in the back, and then complete the evaluation for the CME credit that will be due this Friday. I would also like to thank Dr. Tarbox, who is the Division Chief of Allergy and Immunology, for educating us today. Lastly, if you would like the lecture materials from today, please register on the iEcho website to access the session materials. Thank you.